Hello and good afternoon. My name is Laura Hahn, and along with my co-chair, Susan Manikin, who was unable to be on screen today, we thank you for coming to our first full circle meeting of the year. As some of you may already know, the Education Committee has embarked on a 2-year study of health. This year, we will focus on health disparity and inequity. Across the nation, gaps in health are large, persistent, and increasing, and many of them are caused by barriers set up at all levels of our society. For many, healthcare is a luxury, but it shouldn't have to be. Health equity means increasing opportunities for everyone to live the healthiest life possible. No matter who we are, where we live, or how much money we make. Today, we have the pleasure of introducing you to Vincent DeMarco and Michelle Spencer. Collectively, they have spent more than 40 years working toward educating people on health equity, racial disparities, and health outcomes, and enacting key legislation that increase equity and reduce barriers that stand in the way of healthcare and wellness. We ask that you type your questions into the chat, or you may raise your hand or your digital hand. And when both of our speakers are finished speaking, we will have a question and answer session. Vincent DeMarco is a longtime advocate for public health causes, including reducing teen smoking, underage drinking, gun violence, protecting our climate, making prescription drugs more affordable, and achieving quality, affordable healthcare for all. He played a key role in the enactment of many pieces of legislation. Most recently, in 2019, Mr. DeMarco played a role in passing 3 landmark measures: the Maryland Clean Energy Jobs Act, which increased Maryland's renewable energy requirement from 25% to 50%, the Maryland Easy Enrollment Health Insurance Program, which was made Maryland the first state in the nation to actively use the tax system to find and enroll uninsured Marylanders in healthcare coverage, and a measure which created the first in the nation prescription drug affordability board to make high-cost drugs more affordable for Marylanders. His work has resulted in legislation which has substantially reduced smoking in Maryland, giving Maryland the 4th lowest smoking rate in the nation, reduced drunk driving deaths as a result of the alcohol tax increase, and has expanded healthcare insurance to over 300,000 people. He is also an adjunct professor at the Bloomberg School of Public Health, where he is working to educate public health students from around the world on effective methods of advocating for public health policies. He has also been recognized for multiple accolades and is the recipient of several awards. Most recently, he was named the 2020 recipient of the Andy Hyman Award for Advocacy from Grantmakers in Health. Thank you for joining us, Mr. DeMarco.
Thank you so much, Laura, and I really appreciate this opportunity. I want to thank my colleagues, Suzanne Schlottman and Catherine Kirk-Robbins, who are with me and are going to help me with the slides. But I first want to say we are longtime fans of the Baltimore Women's Giving Circle and have been to your meetings over the years, and think you're a great organization for all you do for so many issues in our city and help so many people. We're big fans of yours. My longtime friend Wendy Cromweiler, I'm glad she's on your steering committee. She's terrific, and I'm thrilled to see that Delegate Brooke Learman is a new member. She is one of the best public health advocates in the Maryland General Assembly. So you have a great group, and we were thrilled when Susan Manikin called and asked us to get together a few weeks ago and told us that you all are making healthcare a priority. Well, that is wonderful. Dr. Martin Luther King Jr. said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And it is absolutely true. When you don't have your health, very little else can mean much to you. And we are very proud of the accomplishments we've made in Maryland over the last 20 years. See, you're 21 years. We're 21 years old too. 1999, going on 22 years old organization. And I want to talk to you a little bit about what we've accomplished in Maryland. But let me tell you, before we turn to the slides, there's a recent article shows that Maryland has the 5th best healthcare system in America, and we're 6th best in the nation in vaccinations. Now, we want to do better, but that's a lot of progress. And a lot of the reason for those great numbers and doing so well are the laws that we've enacted over the last 20 years, which I'm going to talk about. But I want to first say that we are doing very well in Maryland, but there's a lot more to do. There continue to be health inequities, and I'm thrilled to be on this program with you with Michelle Spencer, who's at the Johns Hopkins top national, if not world experts on reducing health inequities. So thank you very much for having Michelle and me here. But let's go to the slides. If I think Catherine is going to set them up. So we are the Maryland Citizens Health Initiative Education Fund, founded in 1999. And let's go to the next slide. As you can see, we are a broad-based, a very diverse coalition. We have hundreds of faith, community, labor, business, and healthcare groups that work with us on many, many issues. And one of our mottos is we need quality, affordable healthcare for all Marylanders. And that's our goal. We're proud of the progress we've made, but we know we have to do much more to achieve that goal in Maryland and across the country. So next slide. I want to start with 2 videos that highlight some of our successes and how we got there. Let's play the dangerous alcohol and tobacco consumption. I'm going to play a video which talks about the dangers to everyone of alcohol and tobacco abuse and how we pass laws in Maryland to address those problems and expand healthcare. Let's play that video.
Sure, we all know tobacco and alcohol can be bad for your health. But the impact doesn't stop there, because the costs spread to everyone else too, from secondhand smoke, increased healthcare costs, and the results of drunk driving. Dangerous alcohol and tobacco consumption is a public health crisis that threatens us all. And as a public health crisis, we need a public policy strategy. The solution is simple and proven to work again and again. Tobacco and alcohol taxes save lives. Take Maryland. When they implemented increased taxes on tobacco in 2008 and alcohol in 2011, they saw dramatic decreases in smoking and drinking, and significant improvements in public health. Because when alcohol costs more, people buy and drink less. When tobacco prices increase, more people give it up or don't start using tobacco at all. This is especially true for young people. And the additional money generated from these taxes? It expanded healthcare for those who need it most. In fact, over 100,000 Marylanders gained access to quality, affordable healthcare through Medicaid. There is no doubt that alcohol and tobacco taxes save lives. To read the report from the ABLE Foundation with these results, and to learn more about how to advocate for these life-saving policies, visit healthcareforall.com/6steps.
So as you could see, we worked hard to enact these laws to increase tobacco and alcohol taxes, which reduced teen smoking and underage drinking and expanded healthcare to many, many thousands of Maryland. But it wasn't easy. And we had powerful opposition from alcohol companies and tobacco companies who usually can stop these kind of laws. But we in Maryland came up with a 6-step approach to overcome these obstacles. And I'm thrilled that one of the people who helped us do all this is one of your members, Sue Talbot, who's been a longtime board member of ours, and I'm a big fan of Sue Talbot. So thank you, Sue, for everything. So I'm going to play for you another video which describes how we overcame the powerful opposition of these vested interests and enacted these life-saving laws. So let's play the second video.
While grassroots campaigns need to be strategic, they definitely don't need to reinvent the wheel. There's a proven path for success already being used to transform public will into political power across the nation, and it's explained in the book, The DeMarco Factor. It's a multi-year process, but we can summarize the main points in under 2 minutes. Step 1. Create an evidence-based policy plan. This is where you work with local experts and grassroots organizations to develop a watertight, proven policy solution. Don't skip this step. This research sets you up for success throughout your campaign. Next, test the plan with a high-quality poll. If you're going to get groups and politicians to sign on to something, you'd better make sure it moves voters first. And don't skimp on polling. Reliable results from a respected firm get you the credibility you need. Now you're ready to build a coalition. Create a resolution for groups to endorse and work hard to get lots of important organizations signed on. Got your coalition? It's time to bring on the media. The more media, the better, because media coverage builds public support for your cause and motivates your supporters. The fifth step is to make your policy into an election issue. This is when you leverage your coalition's strength to make candidates for office endorse your resolution. Then, let the voters know which candidates have endorsed it and which have not. And lastly, go win in the legislature. Because your powerful coalition got the candidates for office to endorse your cause, you begin the next legislative session with the support of a strong number of legislators committed to get the job done. You've built a powerful grassroots movement and are in a prime position for your policy solution to pass. Ready to learn more? Visit healthcareforall.com/6steps.
So I encourage you to look at that website, healthcareforall.com/6steps, to learn more about these 6 steps and our successes, or the book that was referred to by Michael Perchik called The DeMarco Factor, Transforming Public Will into Political Power. And actually, my colleagues, Catherine Kirk-Robbins and Stephanie Clapper, and I teach a class on these 6 steps at the Johns Hopkins Bloomberg School of Public Health, which we're hoping to turn into a summer institute for people who aren't even at Hopkins who want to learn more about them. And in addition to healthcare, we use these 6 steps to advance major measures to reduce gun violence and protect our climate in Maryland, and we're hoping other states will follow this lead. If we go to next slide, I want to talk a little more about our public health victories. The alcohol and tobacco taxes I mentioned resulted in over 100,000 people getting health care in Maryland, even before the Affordable Care Act. But of course, President Barack Obama's Affordable Care Act was the really big win for healthcare in America, the most important since Medicare and Medicaid. And across the country, over 20 million people got healthcare. And in Maryland, over 400,000 people who didn't have healthcare before got healthcare thanks to the Affordable Care Act. And one of the reasons we had such success in Maryland is because we fully implemented it under a Democratic and Republican administration. We accepted the full Medicaid expansion. We created a state-based healthcare exchange, and we did everything we could to fully implement the Affordable Care Act so that our uninsured rate went from 13% to 6%. That is really great. And we hear constantly stories of people whose lives are made so much better because they got health care under the Affordable Care Act. Now, as everyone knows, in 2017, Donald Trump was president, and the Republican leadership in Congress was dead set to overturn the Affordable Care Act. I want to emphasize we are a nonpartisan organization, but we were under threat from Donald Trump and the Republican leadership. They made it clear they wanted to repeal the Affordable Care Act or weaken it. Health Insurance Protection Commission that was created in 2017. I'm very proud to be a member of that commission. And it's chaired by 2 of the best legislators in Annapolis, Senator Brian Feldman of Montgomery County and Delegate Jocelyn Pena-Melnick of Prince George's and Anne Arundel. And that commission, formed in 2017, was charged with figuring out how to protect the Affordable Care Act from attacks at the federal level and how to build on what we have in Maryland and make it stronger. So for a while, we were wondering what we would do if the Affordable Care Act was repealed. Luckily, thanks to Senator John McCain, who had the famous no on repealing the Affordable Care Act, the Affordable Care Act was not repealed. And that was a wonderful thing for Maryland and for our whole nation. So then we talked about how to make healthcare better under the Affordable Care Act and beyond the Affordable Care Act. One of the things that happened under the Trump administration is because of certain policies they enacted or pursued administratively, insurance premiums were skyrocketing for people in under the Affordable Care Act private plans. So Maryland created in 2018 a landmark reinsurance program, which is worked to dramatically reduce insurance premiums for people in the Affordable Care Act private plans. It has been a tremendous success that many other states are trying to replicate. And then in 2019, we enacted, as Laura said earlier, something very exciting called the Easy Enrollment Insurance Program. The Easy Enrollment Insurance Program is directed toward the many Marylanders who are eligible for free or low-cost health care, but can't afford it. Free or low-cost health care, but don't know about it, don't know that they're eligible. So they can get free health care, but they don't know they're eligible. They have so much going on in their minds and in their lives, they don't sign up. So now Maryland is the first state where at tax time, all of us are asked, are you uninsured? If you answer yes, then you're asked another question. Can we at the comptroller's office share your tax information with the health exchange and get you enrolled? And as you see on the slide, over 6,000 people have signed up for healthcare through the Easy Enrollment Program. And we think a lot more can sign up. And we're working on making the Easy Enrollment Program work better with automatic enrollment if you're eligible for Medicaid, and for really making it very easy for people to enroll. We did focus groups with folks who are uninsured, but eligible for free or low-cost healthcare. And we found that it's just very difficult for people a lot of times in these situations to do what's necessary to get healthcare when so much more is beating down on them from so many directions. But if you do something like Easy Enrollment, it works. And the easy enrollment law was sponsored by delegates Jocelyn Pena-Melnick and Senator Brian Feldman, and several other states, Colorado and Virginia, have enacted easy enrollment laws, and all across the country, other states are following us. And our wonderful United States Senator Chris Van Hollen is about to introduce a federal easy enrollment law to have it happen at the national level, so that everybody paying taxes would get an easy way to get enrolled in healthcare. So we're working hard with Senator Van Hollen to make that happen. So the easy enrollment law was a big win for people of Maryland, and we hope for people around the country in 2019. Now this year, thanks to Delegate Laura Charkoudian and Senator Jim Rosapep, we got another law passed, which will put an easy enrollment checkbox at unemployment insurance time. So a lot of people, when they lose their jobs, also lose their health insurance. We want them to very easily know that they can apply and get free or low-cost health care. So there'll be a place where they can say, I'm uninsured, and they can be connected and get health care. That was enacted this year. We hope will take effect soon. It's not in place soon, but their Labor Department is working on implementing that. So that was great from also from this year. Another great law that passed this year provides additional subsidies for young people. Now, there are some folks who, even with the subsidies available under the Affordable Care Act, still can't really afford the insurance. Luckily, under President Joe Biden and Vice President Kamala Harris, who we are thrilled are fully committed to the ACA and making it even better, we got enacted the American Rescue Plan Act in earlier this year, which provides additional subsidies starting November 1 for lower income people. And in Maryland, in a law sponsored by Senator Brian Feldman and Delegate Ken Kerr of Frederick County, we're now providing additional subsidies, additional $20 million in subsidies over the next 2 years for young people, ages 18 to 34, who can't afford the health care under the previous subsidies. So as of November 1, there'll be additional subsidies for everybody, but especially for young people in Maryland. These were some really good. We also understand that outside of the scope of the Affordable Care Act, there are some very deep problems that we need to deal with. One is the escalating, incredibly unconscionable costs of prescription drugs. it really is unbelievable how much we are gouged by the drug companies. We pay substantially less for our prescription drugs than people in other countries, substantially less. And in addition, when the drug companies scream and yell about, well, we have to make these prices high because that's how we can afford the investments in research, that turns out to be false, because we know that they spend a lot more on advertising than they do on research. The United States and New Zealand are the only countries that even allow the drug companies to advertise their drugs. And all those ads you see on TV are costing the drug companies so many millions and millions of dollars, which they could be putting into making the drugs more affordable. So we were able to use those arguments to enact in 2017 an anti-price gouging law, which unfortunately was declared unconstitutional under the so-called Dormant Commerce Clause. We prohibited the drug companies from gagging pharmacists from telling people about lower cost drugs. But we did in 2019, same year we enacted the easy enrollment law, enacted the first in the country prescription drug affordability board. This is a very exciting development. This board, which is comprised of 5 people, chaired by the terrific former Health Secretary Van Mitchell, is in the process of figuring out how to make high-cost drugs more affordable for Marylanders. And they have the authority to make high-cost drugs more affordable for state and local governments, which they will do soon. We need to go back in 2023 and give them the additional authority to make high-cost drugs more affordable for everybody. But the fact that they're there and working is tremendous progress. And we are working with states all around the country to enact similar laws. Colorado enacted a really strong law this year, and Oregon enacted a prescription drug affordability board. And in nearby Virginia, the Democratic nominee for governor, Terry McAuliffe, has endorsed this and is running on it and is saying he wants to do a prescription drug affordability board. We know that New Jersey and many other states, leaders are trying to enact a prescription drug affordability board. As you know, prescription drug costs is one of the big issues at the federal level, where there are efforts to allow Medicare to negotiate with the drug companies, which only makes sense. It doesn't make sense that Medicare can't negotiate with the drug companies while the VA can, and the Veterans Administration can get better prices, but the Medicare cannot. So hopefully they will accomplish that. And based on our law, Senator Chris Van Hollen is trying to get into the federal law the creation of a board like the prescription drug affordability board. I'm really excited about the prescription drug affordability board, and we are going to let you all know early next year about the plan they announced to make prescription high-cost drugs more affordable for state and local governments. We'll have forums across the state, and we'll certainly invite you all to participate in that. So this is tremendous progress. In addition to high-cost drugs, another deep-seated problem are serious health inequities. And Laura mentioned that at the very beginning, and we are really thrilled that the Baltimore Women's Giving Center is making reducing disparities a priority. We see in Maryland zip codes really close to each other geographically, with dramatically higher death rates, a lower life expectancy in predominantly African-American zip codes than predominantly Caucasian zip codes. That is just unacceptable. And there are many other measures of how disparities hurt people of color and people in disadvantaged communities. In 2012, when Michelle was at the State Health Department under Governor O'Malley, Lieutenant Governor Brown, there was enacted a new program called the Health Enterprise Zones, which was around for 5 years. Unfortunately, it was not renewed. It was a pilot program, which worked very well to reduce health disparities in those zones that were created. And Michelle will talk more detail about what happened in those zones and what's going to happen next. But this past summer, Senator Antonio Hayes of Baltimore City, Delegate Eric Barron of Prince George's County, and Delegate Jazz Lewis of Prince George's County approached us and said, we want to renew those health enterprise zones and get them going again. It's really, we agreed, ridiculous that they were allowed to lapse even though they were working. So we worked together and we built a strong coalition. Many of you in this audience were part of the coalition, and we enacted what we call the Health Equity Resource Communities law, which over the next 5 years will put $59 million into reducing health disparities. Now, let's compare that to the health enterprise zones. For 5 years, they had about $15 million. And even with that $15 million, they had some good successes. Now we have $59 million. It was a really tremendous move forward by the General Assembly. And the program is being run by something called the Community Health Resources Commission, which is a really great organization that has been giving grants on healthcare for many years, but now they are running this program, and they are going to be having forums across the state to let people know about how to apply for the grants, and they're going to put out the first request for proposals in a couple of weeks, and they'll be readily available on their website and our website, and any organization or entity that believes that they have a way to make healthcare more accessible for people in disadvantaged communities and reduce health inequities can apply for these grants. They have to apply by mid-December. And we're looking forward to moving forward with these grants and moving forward with this program. Right now, the grants are going to be to individual organizations and something called the Pathways to Health Equity. But starting in 2023, groups will come together and form what Michelle will talk about in more detail, health equity resource communities, applying for major grants for large communities. But we hope that this will be a real model for the whole country on how to reduce health disparities. So let's go to the next slide. I want to talk to you for a couple minutes about what happens next. It's one of our mottos and ways of working that we never just stop after getting a law passed. We work very hard to make sure the law is fully implemented. When we passed in 2007 a tobacco tax increase that expanded Medicaid to 100,000 people, we worked with then prominent Ravens football star Ed Reed to do radio ads to let people know that Medicaid was there. And thanks to our work and the state's work, over 100,000 people got the health care they needed. People need to know about these new opportunities that are there. So a big date for everybody to remember is November 1, 2021. That is when open enrollment begins. Open enrollment this year is particularly important because, as I said earlier, there are new subsidies under the federal American Rescue Plan and under the youth subsidies law. So people who may have in the past said, oh, I can't afford that health care, now it may be affordable to them. So we have a flyer and we have many other ways that organizations can get the message out to people to try again. And to, especially if you're a young person, try to get the health care you need. So you can go to our website, healthcareforall.com, and see all this. And we encourage you to join us on October 12th at 7 p.m. for a webinar. We're going to have on that webinar some of the key legislators, and we're going to have someone from the Maryland Health Benefit Exchange who will talk about the new subsidies, and someone from the Community Health Resource Commission who will talk about the health equity resource communities. And Michelle Spencer will be there, who's on the advisory committee to that body on these laws. So we encourage you to spread the word to your members, to be on that webinar and find out about all these new great healthcare opportunities. Let me just conclude by saying we always can use help, and there's a way to donate to us if you want to do that. But mostly what we want from you help us spread the word. You all are people who are very well connected in your communities. If you can get the word out about all these opportunities that are available, that would help us tremendously. And again, as I said at the beginning, we are big fans of the Baltimore Women's Giving Center, Giving Circle, and we thank you for this opportunity. And I'm going to turn it back over to Laura, who will introduce Michelle Spencer, who you will see is a great person who has helped Maryland much in the past, is going to help us in the future. And I look forward to answer your questions after Michelle's done.
Thank you so much, Vincent. We really, really appreciate all of the great information you gave us. And I'm looking forward to asking a couple questions myself if there's time. So our next speaker is Michelle Spencer, and she is a public health practitioner who focuses on the impacts of health equity, racial disparities, and health outcomes through community-based initiatives. She is the Associate Director of the Bloomberg American Health Initiative and an Associate Scientist in the Department of Health Policy and Management. Ms. Spencer has over 20 years of experience in public health management and leadership, and a wealth of experience in administrative and operational management, strategic planning, research management, and policy development. As Mr. DeMarco mentioned, prior to joining the Bloomberg School of Public Health, Ms. Spencer served as the Director of Prevention and Health Promotion at the Maryland Department of Health and Mental Hygiene. She worked to address preventable public health challenges. And Ms. Spencer, while she was there at the Department of Health and Mental Hygiene, she oversaw core public health programs, including the maternal and child health, infectious disease epidemiology and outbreak response, infectious disease prevention and health services, environmental health, primary care and community health, and as Mr. DeMarco mentioned, she led the Health Enterprises Zones Initiative, an initiative that focused on designing and implementing strategies to reduce and eliminate health disparities. Welcome, Ms. Michelle Spencer.
Thank you so much, Laura, and thank you all for the opportunity to be here. I also wanted to express my thanks to Susan and to Martha and to Jeff for all of the support and assistance in being here. I also wanted to thank the executive committee for the opportunity. And I think as we were entering this space, I was looking at the values, and the noted values included equity and inclusion and connection and relationships, collaboration and learning. And that is certainly what we are, my passion, and certainly what we are striving to do when we think about ways to implement policies and programs that are impacting individuals at the community level. So thank you again for the opportunity to be here. I'm going to share my screen and get started with these slides. And as we noted earlier, I do look forward to the opportunity to answer any questions that you may have as they come. And I appreciate Vinny's presentation and all that we're learning and doing together across the state of Maryland. And one of the things that you will hear is, when we do these programs, other states are really looking at what we're doing here in Maryland and using it as an opportunity to think about what policies and what programs that they themselves can begin to implement. And so again, thank you for the opportunity to be here. A brief outline of what we'll be chatting about: the background, the response, the zones, monitoring and progress, progress and outcomes, a little bit about our lessons learned and our next steps. One of the things that were noted back in 1999 by the Institute of Medicine, the determinants of health are beyond the capacity of any one practitioner or discipline. And I just love that, because then it certainly goes back to collaborative approaches to the way we address the issues of health disparities in healthcare. The World Health Organization noted that social determinants are, I skipped ahead, I'm sorry about that, but social determinants are the medical factors that influence health outcomes. And these include, as all of you know, income and social protections, education, food insecurity, housing, and environmental health and environmental issues, just to mention a few. And so when we think about this collaborative partnerships that are beyond the medical factors and the medical system, certainly we recognize that. So you may know the cost of health disparities in Maryland, right? It's between 1 and 2 billion per year. And this was back in 2011. And accounting for so much of that were excess charges for Black and white hospitalization disparities, right? Alone, which were over $814 million. And certainly we see a need here and a desire. What is driving the way we're thinking about this? Vinny mentioned health disparities, and here Dr. Lisa Cooper at the Johns Hopkins University School of Medicine, Nursing, and Public Health indicated that in Baltimore, there's this 5-mile difference in terms of those who live in the Roland Park community versus those who live in Madison East End. And you'll see here that the income in one part is about $60,000 more than another area of this within 5 miles within Baltimore City. Two Baltimore City neighborhoods that has a difference of over 18 years, right? Over 18 years. In terms of life expectancy and within only a 5-mile radius. We know, and I see here that we recognize that the areas with the worst health outcomes and the most health disparities also cost the state the most money. And so what is the response to that? What are the things that we should be thinking about? What are policies that we should be implementing? How do we use the data that's before us to really make change? And so we see here that Senate Bill 234 back in 2012 was established and enacted, and it was the Health Improvement and Disparities Act. It provided $4 million per year for 4 years to support the Health Enterprise Zone Initiative. And really the tenets of this was to reduce health disparities, improve health outcomes, and reduce healthcare costs and hospital admissions and readmissions in specific areas of the state. And how do we go about doing this, right? And so what is it and how do we go about doing it? So we understand the charge. The HEZs, they're designated local communities with documented poverty, health disparities, and or poor health outcomes where special incentives and funding streams are available to address health outcomes by using healthcare level, community level, and individual level interventions. The HEZs must be, and you see here, must be a community or a contiguous clusters of communities that are defined by the zip code boundaries. We must have a population of at least 5,000 people. It must demonstrate greater economic disadvantages and poorer health outcomes. And it must be a population that was small enough to allow for the incentives afforded under the Act to have a significant impact on improving health outcomes, but large enough to produce measures at the zip code level so that they were stable and there were indicators of disparities as well. And you see here some of those indicators in terms of Medicaid enrollment rates, WIC participation, as well as low life expectancy and the percentage of low birth weight for infants, and using those as markers of measures. The Maryland Department of Health produced these maps with zip code level data, and really helped using these maps helped communities that were applying for the grants to think about and to recognize whether they actually would qualify to be part of the HEZ. So the Department of Health really wanted to ensure that tools were in place as individuals were completing their applications to recognize whether they met the criteria to be a health enterprise zone initiative or health enterprise zone. So the designation there were 19 applications that were received. Applications came from 16 jurisdictions. 5 of those were designated, 5 zones were designated in January of 2013. They represent rural areas, urban areas, and suburban areas. 3 of these were led by coalitions of hospital and health systems. 2 were led by local health departments. And each zone was unique. It was tailored in its program and in its resources. And one of the things that we always say is that if you see one zone, you've seen one zone, because they were so different and so unique. And I'll talk a little bit more about this in just a moment. It's important to note that when we were thinking about reviewing these applications and considering funding, that the principles of these 6 strategies were included in our decision-making processes, ensuring that we thought about health disparities and really working with the Maryland the Maryland Office of Minority Health and Health Disparities to ensure that we were incorporating these measures, thinking about cultural and linguistic and health literacy competencies, workforce diversity, racial and ethnic language data, and certainly addressing social determinants of health and thinking about provider and community focuses and balancing that as well. So the incentive programs, it's important that when we thought and were developing the legislation, that there were incentives that were created for communities to attract practitioners to areas, right? Thinking about HPSA designations, thinking about rural communities that may not have access or maybe traveling several hours to get to primary care physicians, and ensuring that we had some incentives in place to really think about those practitioners who may be interested in coming to the area and providing incentives for them to do so. The broader healthcare environment, when the HEZs were implemented, I always think it's critically important to note that Maryland was ending its first open enrollment period. We were also part of global budgets and part of the all-payer model. And as you know, Maryland is a Medicaid expansion state. We were integrating community health workers. We were thinking about patient-centered community-based models, understanding the significant impact of community health workers, as well as their intervention on disease management and health outcomes, and the critical importance of what community integrated medical homes look like. Now, a little bit about the zones, right? And so if I just take a few minutes to talk about each of these zones, I said again at the beginning that the tenets of this legislation was to reduce admissions and readmissions, reduce healthcare costs, and reduce health disparities. And I will say, and admittedly, that reducing health disparities over 4 years is not the easiest thing to do. And I know that all of you are well aware of that. That slide that I showed, that there's a 5-mile radius, and yet there are 18 years of life expectancy in terms of that gap. Like, that didn't happen overnight, right? Like that there are systems in place, there are policies in place. And so when you think about how do we approach reducing health disparities, it's a process and it's a system, and it's very intentional in the ways that we approach this. And so you'll see here on each of these 5 slides that I'll share that each of the zones their targeted outcome was really focused on being very specific, either in managing a chronic disease, in patient health outcomes, focusing on disease management, focusing on those things that really are preventable at the community level. And so here in Anne Arundel Medical Center, what they did is they used the public housing building and established a community health center within a housing building. That housing unit had 184 residents, and really what Anne Arundel County did was Anne Arundel Medical Center looked at the number of emergency room calls coming in, where they were coming from, and determined that if they provided service within the community at that housing unit, that they would begin to lower the number of 911 calls, the number of ER visits, and the number of individuals who or admitted or readmitted for those particular issues that could be dealt with within the community and within the home. Caroline Dorchester really focused on decreasing hospital and ER utilization as well, thinking about behavioral health, diabetes, hypertension, and focusing on adult and childhood obesity. And you'll see here that they really expanded many resources within their community, thinking about creating a mobile mental health crisis team. So again, addressing those things that can be done within community. They instituted a weight management program, a school-based asthma management program, again, looking at the data and determining what are those things that can be done within communities and managed within communities. Greater Lexington Park, a rural community. This particular zone was based at MedStar St. Mary's Hospital, and they implemented the care coordination community health worker wraparound program, really targeting high utilizers, right? Like thinking about who are those individuals, looking at their 911, what does the data say, and then going to those individuals and managing their care within their homes and recognizing what could be done. I will share with you a story of a more seasoned couple who had problems understanding the dosing of their medication. And God, like, bless her, she was trying so hard to help her spouse with his insulin and was just reading it wrong, and recognized that he was constantly still going into the emergency room. And what they ended up doing was having a community health worker go to their home on a more than weekly basis, more than one time a week, to really ensure that they understood, but also to help her manage his diabetes and his medications around that, right? I can share with you that in Anne Arundel County, for that particular housing building, there was Mr. P that we talk about and think about, who was utilizing the 911 ER system because he wanted connection to community, and found that when he went into the emergency room, he was able to be there and talk with individuals. And what Anne Arundel Medical Center did was gave him a volunteer position, right? And so it connected him to the kind of social supports that he was needing and looking for without him having to utilize 911. And also within the housing, that clinic that they opened, Mr. P was like the point of contact to help the clinical staff understand what was happening with some of his neighbors within that building. So really thinking about what are some of those clinical and non-clinical social supports that can be in place to address community health. Prince George's County really focused on reducing preventable hospital admissions again and emergency room visits, developed this health exchange across the county, but also with DC, given that many residents within Prince George's County would also go across county lines to DC for care and services, and understanding who those individuals were to be able to target them in a very direct way, and providing a health literacy campaign as well. West Baltimore Primary Care Access Collaborative was out of Bon Secours hospital system, and they really thought about what are those prevention methods. Again, what are the things that are happening in community, focusing on diabetes, cardiovascular, eating, nutrition, exercise, and a number of different incentives that they provided as well to community members, to have them come in and recognize, here are the things that needs to be done to address your care within the community. And then also providing mini grants to community partners to really manage care within their zip codes areas as outlined here. This is a snapshot of all that I've just shared, and it also includes, you'll see here, the budget and the specific populations that were served within the number that were served within each of those five zones. I want to talk just a little bit about monitoring progress and outcomes. So one of the things that we are very proud about, Health Affairs with researchers at Hopkins, Dr. Gaskins and Dr. Thorpe, really did an evaluation of the HEZs. And the findings from the evaluation, this was published back in October of 2018. The findings indicated here that the net cost savings from reduced inpatient stays far outweighed the initiative's costs to the state. They also noted that implementing such an initiative is a viable way, right, to reduce inpatient admissions and reduce healthcare costs. So this is really focusing on the financial costs of reducing, of utilizing the healthcare system, and what that does for the state. But I want to show you some data, right? It can't be from Hopkins and thinking about policy without sharing a little bit of data. And so you'll see here that the researchers compared the HEZ zip codes to eligible zip codes that were not funded. And what you'll see here is that the discharge per residence for those zones that were awarded had a decrease versus those HEZs that were eligible and not awarded. So there is a percent difference here of 31%, a decline in the total discharges per capita for between 2010 and 2016 versus those that were eligible to be a HEZ but were not awarded, and that was about 24%. So we see that there's a difference there, but with specific thinking specifically about what are the things and innovative approaches within the zones, and we see that there is a substantial decline there. Similarly, PQIs are those conditions that can be treated in community versus in the hospital. And you see, again, there is, for those that were awarded, we see the steady decline between 2009 and 2016. And again, 2012 is when we really began, when the HEZs were implemented and where we begin to see intentional approaches to how we think about community health and how we approach care in community. And then for the emergency room visits, for emergency department visits for the HEZ and PQI, we continue to see, it looks like the emergency room visits for HEZs is faster in those awarded than those in the eligible zones, but those zones that were not awarded. And we believe that if the zones had continuously been funded, that we would continue to see that decline in emergency room visits as well. Again, thinking about care in community versus care within the medical system. Just wrapping up really quickly, for process evaluations, 21 healthcare delivery sites were opened across the 5 zones. Almost 100 new FTE were added or retained, including licensed practitioners and other licensed and healthcare practitioners, several community health workers, and we see that a number of tax credits were awarded, as well as those exceeding over $300,000 for across the zones. And we also offered loan repayment assistance to many of the practitioners that were interested in coming into the zones. For the process evaluation, we had a number of care coordination of high utilizers. We linked many of our data systems to facilitate data sharing and the complex management of some of our patients, and certainly thinking about what community supports needed to be addressed to reduce social determinants of health. And then in terms of lessons learned, timing, right? For the HEZs, we needed, these zones were funded and then they immediately began with implementation. So a year of planning would have been helpful. And so as Vinny noted, the new legislation, the HERC legislation, we are really being thoughtful about how we approach and what we are thinking about in terms of funding when these new sites are awarded, allowing opportunities for these communities to have time to really build and think about all of the different structures that need to be in place before they actually start implementing. And again, this was an innovative approach, and innovation requires some level of flexibility. It requires funding for things that may not necessarily have been thought about or were in the initial proposals, and certainly accounting for the broader healthcare environment and being thoughtful of that. We also needed to think about recruitment and retention for our provider community, thinking about ensuring that they were balanced between community and provider focuses, and being intentional about the way we created these and the way we approached this. And again, as I said earlier, one zone, if you saw one HEZ, you saw one HEZ, because there's a tailored approach to the way each of these zones really approach their work and implementing their particular initiative. In terms of progress and next steps, I showed you health affairs, the cost the cost benefit of this. But the conclusion here, I just wanted to highlight, is improving access to care and reducing healthcare costs are key factors to reducing disparities. And if you look a little bit further, it also notes that the program, I think here's what I really wanted to point out. It also, the HEZ also supported the coordination of healthcare and social services for vulnerable populations, right? And so we don't just do the work to do it, but the conclusion indicated that not only was there a cost benefit to this, but that there was also a human and social service cost to doing this initiative as well. I'll share with you that the zones has numerous awards, has been recognized, has been replicated in different areas, has been used as, there's been publications, has been replicated in Philly and Rhode Island. There's several initiatives going on in New York based on what Maryland has done. I'll also share with you that, as Vinny talked about, the new HERC, right? The new HERC legislation and all that we're doing and all that he's been able to do to really get us to this moment. It is a win for Maryland, the way that we were able to approach this. And you'll see here that House HR 4510 was introduced by Congressman Anthony Brown in the 117th Congress, really thinking about how can this legislation from 2012 that is now that has now passed in terms of new HERCs and pathways grants, how can that be done at now at a federal level? And so Maryland is really truly a leader in the way we approach this. And as Vinny said, we're the 5th best in healthcare in America. And so how do we continue to mobilize using the tools that we have here, but also to help other Marylanders across our state? I wanted to share some of the supports that Vinny noted earlier, right? 65% of the community, Marylanders, were supportive, were in favor of this legislation, over 65%. And we were thrilled to hear that. But yes, here, the average life expectancy by neighborhoods you see in Baltimore City versus Prince George's County, there's still more for us to do and still much more progress to be made. But I think we have made good strides, and we are certainly at a place and a point to be impactful and to continue to do the work in ways that make a difference for Marylanders. Now, I think just about my last slide here, the HERCs, 59 million in new funding over the next 5 years. 14 million will be for pathways grants, and there will be the first statewide meeting on October 14th at 4 o'clock. It will be virtual to really talk and share about what these look like. What are these pathways grants? What does the RFP state? And then within 2 years, there'll be another $45 million that will be available for HERC. So we were able to accomplish a lot with 16 million over 4 years. I can't imagine what we're going to be able to accomplish with 59 million, really dedicated to thinking about equity, thinking about disparities, and reducing and improving, right? Like from not from a deficit perspective, but from a perspective of what we can do to really improve the lives of Marylanders across the state. And so with that, thank you for the time, and I look forward to questions.
Well, I wanted to say thank you again to Michelle and Vinny for taking the time and for enlightening us and educating us and giving us so much more to think about and to chew on. So we really appreciate the opportunity to meet you and to hear you speak.